Give me 1 sec. There we go. So what we're going to do is continue on and start looking at some specific disease processes that go along with aging. Now, a week or so ago, I had sent out to you a paper called The Cellular Basis of Aging. And the cellular basis of aging was a paper that was written back in the 1980s, late 70s, early 80s, but it was published here in the Western Journal of Medicine back in December of 81. And it's just one of those things that, knowing your history can help you redoing what you're doing now in the current situation. But basically what this paper came down to say was that normal cells have only a finite lifespan before they die. This very, very simple concept, which we know because guess what? We've been being born, we've been living, and we've been dying for pretty much a long time. Somebody finally put it and wrote it down. But what they didn't know is, and this is where the research has come in over the last 30, 40, 50 years, is why do normal cells have a finite lifespan? We didn't know why. Why do certain things affect the cells like they do? And what they've done here is, after a lot of research, is basically at the chromosome level, the chromosomes, again, located in the nucleus of every cell that we have that's still alive and able to mitose. Basically, what they figured out over this longitudinal study is the telomere, the very tips of the various chromosomes, when they come together before they mitose, before they duplicate and replicate themselves. As you get older, what happens is those telomeres begin to shorten. And as those telomeres begin to shorten, they start losing their genetic quality of the data, the RNA, DNA that is located within those chromosomes. So here, this is the cellular basis of aging. But here you can see a normal cell here under electron microscope that has been irradiated with some type of irradiation element here, and again, this shows down here at the bottom, this is 10 micrometers. That length, 10 micrometers, very small, which a micrometer is 10 to the negative 6. It's extremely small. So what they did here under electron microscope was they took a picture of a normal cell. Then they took a picture of the normal cell next to a cell that is aging. And here you can see that this cell, the one here on the left, all right, this one here on the left is normal. The one on the right, as you can see, the cellular membrane is starting to break down. It does not have a lot of these irradiated chromosomes floating around in the cytoplasm. Here you can see it start breaking down. So just take that as an analogy as what happens when we get older, from the skin to the individual cells to the brain to all the tissues in our body. Because of the loss of these telomeres, they can no longer reproduce. Things get old. Look at your old Nintendo. Look at your old dishwasher. Look at your old, anything that you have. Look at a pencil that you sharpen to do your work. All of this stuff does not regenerate, and it shrinks and it gets older. It becomes broken down over time. And that's what happens to the general physiology of the body with that. So that's what we're going to talk about as we go along throughout each individual system. So because of this overall breakdown, we'll begin seeing an increase in probability of disease. We'll see that. Even, the oldest living individual, I believe, was 117 years old, and they just started breaking down. Little things, stepping off curbs, started breaking bones. Problems breathing and everything else like that. The human condition is such that it is finite. Some go earlier and some go later. And then because of this probability of disease, this overall modifies the threshold when signs and symptoms begin to occur. The old adage is, you start feeling older at 40, and that becomes noticeable even if you've never had any disease process or broken anything. Usually right around that 40 age group when things start cresting over for males. You're looking at decreasing in testosterone, decreasing in muscle mass, females decreasing in progesterone and estrogen, all that other stuff. It goes down. Things start to pop, crack, and snap, crackle, and pop in that morning. So one of the things that we see initially is in the respiratory system, decreased chest wall compliance. And again, we'll talk about COPD, smokers, and all that other stuff. But with that decreased chest wall compliance, we start seeing the loss of the lung capacity, as well as elasticity in that. Things just become harder, whether or not somebody's had pneumonia over the years, the smokers, the vapors, or something like that. It just starts breaking stuff down. Those smaller airways start to collapse, and we end up trapping in those smaller airways. Things can't get out, so they start building in. And that's where you start getting that barrel-chested of your COPDers and your emphysema patients. Reduce overall strength and endurance of the respiratory muscles, because most people are not running, after the age of 40 to 50. The general population are not exercising as they once did, or their overall activity is decreased. At age 65, we actually can measure that our overall vital capacity of our respiratory system reduces by 50%. So if we're bringing in approximately, 500 mLs per deep breath, but there's also the excess capacity, vital capacity, that whole amount, which is about 1,250 mLs, we're going to reduce that down to about 650, 700 as you get older. So with that point, you tend to see elderly individuals have a slightly higher respiratory rate than the normal 10 to 12 because they need to make up for that loss in vital capacity. We'll see an overall decrease in ventilation, though, because they have to breathe quicker, smaller volumes of air coming in to maintain that minimum of 500. Okay, and with that, based on disease states, we may end up getting a progressive hypoxemia, low oxygen, therefore higher CO2 retention, which there's that hypercarbia. That will affect either our end reliance of acidosis versus alkalosis at the pH system. With that, we'll see a decrease in the overall cough reflex, again, as they get older. That can lead to choking, dysphagia, inability to, problems in swallowing and everything else like that with that. And is because of that, also, we see a decreased activity of the cilia that traps things and brings up. That's why most of the time, as you get older, when you get up in the morning, one of the first things you're going to start doing is coughing, especially if you're a smoker or a vapor. What ends up happening is that cilia, what's left of them, instead of being burned away of the respiratory tract, they work at night and they lift all that stuff up, the mucociliary escalator or elevator system of that. So as we go along here, we'll see all that kind of stuff. Some other things that we'll see which it decreases our overall respiratory effectiveness is kyphosis. Musculoskeletal system of the back, and how the back, based with osteoarthritis, maybe alkalizing spondylosis or something like that, trauma, can affect our respiratory system. Exposure to pollutants. We live in a dirty world. Whether you may not vape, somebody next to you does. Maybe there's somebody that smokes. What about particulate matter of being on farms, particulate matter of the waste of vehicles? Working in a pizza shop, you never would have thought of this, but what happens if you work in a pizza shop and you're used to throwing pizzas up and around? What about all that dropping flour that is now into your system? What about those black lungers that have, the elderly population that still worked in the mines or something like that? Those are all issues as far as, chronic exposure to pollutants. If you work around, hazmat scenarios, you clean with bleach constantly or something like that. These are all issues that can lead to problems with that. Long-term cigarette smoking, vaping, all that other stuff we've talked about. And again, marijuana use. Please remember, we're talking people over the age of 50 to 60 now that grew up in the late 60s and 70s where the use of marijuana was very prevalent, as well as other different types of pharmaceutical agents like cocaine, and learning how to smoke, pretty much everything. Now, with these elderly individuals, positioning is very important for adequate breathing. If you have somebody that is in congestive heart failure, if you have somebody who's a COPD that is trapping air, one of the worst places, especially if they're obese, one of the worst positions you can put them on your stretcher is completely supine. You do that, they're going to start fighting you, and one of the responses to hypoxemia is going to be fight response. Some people, younger providers, may think that that's a patient being aggressive, when in reality, it's a normal physiological response to hypoxemia. Bronchodilators help a lot, whether it's a Duaneb, whether it's an albuterol. Now with COVID, we're seeing an influx of the utilization of terbutaline. So all this other stuff, as well as giving a little bit of oxygen. It may not have to be a non-rebreather or something, but using all of our assessment skills, looking, listening, looking at the patient, how they're interacting with the environment, pursing lips, nasal flaring, tripoding, utilization of a pulse ox as well as capnography can help us define what a good oxygen level is. And if we have to give it to them, even though there's a lot of research that says, excess oxygen for long periods of time are bad, there may be some that needs supplementation. If not, PEEP, and that's where our CPAP and BiPAP come in down the road. And again, you got to remain attentive for any type of complications with patients. You just can't sit there and assume that the status quo is going to remain the same. Monitor their ventilations closely, in the fact that, and we're seeing this now, especially with the COVIDs, but also with other medical conditions. They can go from breathing regularly to going to flash pulmonary edema in less than 10 minutes. So be mindful of that. Please realize that respiratory and cardiac diseases in the elderly usually go hand in hand. If they have one, they usually have the other. Put them on a monitor, and give them maybe an IV. New research is coming in. Do we need to give everyone an IV? Maybe, maybe not. It's going to be up to your clinical decision and your protocols to be able to decide that. But if you do give fluids, give them judiciously, because these individuals have reduced peripheral vascular areas that may or may not be able to handle a lot of fluids. Now, this is just a follow-up on what I talked earlier about how the spinal cord can be involved in an individual's respiratory pattern, as well as how well they're breathing. The concept of kyphosis is a name that goes along with abnormal curvatures of the spine. Okay, so if you have somebody that is suffering from what is known as lordosis, okay, a kyphotic spine just usually is the general term, but they're actually broken down into three types: lordosis, which is hyperlordosis, hyperkyphosis, or scoliosis. Whereas when we see the hyperlordosis or lordosis, what we see is this area down here in the lumbar region, where the lumbar area pushes out. And the reason for that is the hips need to be pushed out a little bit more to become in a vertical concept to hold the head and the thorax in line with that. Most individuals that we see that suffer from lordosis, it is a transient issue, are females who are pregnant, especially late second and third trimester, because the child's weight is bulging out here, whereas when a child starts sticking out here, that weight is transferred over here, which then means this and this need to come over for proper gait over top of that hip. So that typically goes away after the baby's born. We can see a little progression of it, but as people get older, because of this buildup of the belly fat, we will see that going on more with the lordosis or hyperlordosis. And this is why in this area right here, L1, 2, 3, 4, and 5, L1 through L5, this is the area that we're going to see that is most injured in these individuals with spinal injuries because of that weight being carried over. When we start getting into this kyphosis, especially when with osteoarthritis, with the elderly, what we'll see is this hyper K view. All right, this bending over from, when we start getting towards, T11, T12 down here, about to C7, C6, C5 in this area. Now, because of that, think about how our ribs are connected. Ribs are connected this way, they expand out and back in. And because of this hardening of these and this movement, this reduces our overall ability to expand and contract our lungs, which decreases our overall efficacy of bringing in that oxygen. All right, with that. So what we'll end up seeing are these individuals who, one, cannot lay flat, because again, it's trying to lay somebody flat like this. This also becomes problematic if we ended up needing to do CPR on somebody with this kyphotic spine. Doesn't work very well. Individuals can't lay flat. These individuals are usually side sleepers or end up sitting with 2 or 3 pillows to keep themselves up. But that's kyphosis, this hyperkyphotic issue that keeps people sitting up and decreases their ability to bring in vital capacity. Now we end up having scoliosis, and again, the scoliosis looks like an S. Scoliosis typically, as individuals get older, also have muscular dystrophy, multiple sclerosis, all these little things that affect patients as well as trauma with that. Does anybody have any questions on lordosis, kyphosis, or scoliosis? All right. Oops. Stand by. Got to figure out how to go to erase on my drawings. There we go. All right. So cardiovascular system. Overall in cardiovascular system, something that we've worked pretty much our entire program on, and how to interpret EKGs and everything else like that. Let's look at the cardiovascular system in how things influence its overall function. One, diet. Okay, are you eating the right things? Are they eating high fiber, high protein, low fat, stuff like that? Probably not. So diet has a big influence on the overall cardiac function. Overall physical activity, it's hands down, nobody can argue it, but getting up and moving around for a half hour, 45 minutes a day not only is helping cardiovascular and respiratory health, but general mental wealth as well. Smoking, and again, just not cigarettes. We're talking about vaping. We're talking about marijuana. And just please don't come out with those common misconceptions of age that cloud your assessment. Remember, there are grandmas and grandpaps out there that like to hit the bong, that like to roll a fatty every once in a while as well, especially now with medicinal marijuana and everything else like that. So somebody that's been hitting in and it smells as patchouli sticks when you walk in, hey, maybe assume the fact that there is some influencing there from some marijuana. Is there a increased use of alcohol use? We'll talk a little bit more about esophageal varices and, cirrhosis of the liver, which ends up causing a backup in the hepatic portal system, which causes, right-sided and left-sided failure. It affects preload and afterload, which ultimately will affect cardiac output. What's the education of the individual? If somebody has a 4th grade education, they're living in the mountains of Appalachia, and they have Mountain Dew teeth, more than likely they don't know that 1 or 2 eggs a day is good, but cooking that in lard fat is not that good. Smoking 4 packs of Marlboro Red so they can get a new jacket is not in the good aspects. Their idea of getting up and having fun is sitting in their rocking chair, or maybe even riding a tractor or doing something where they're sedentary all the time. What's their overall socioeconomic status? Please remember, it's much cheaper to buy garbage food and higher fat food than it is to go buy healthy foods. So you'll see issues that go along with cardiovascular disease with their overall socioeconomic status, as well as personality traits. Those we really can't change. Those are, the characteristics that we can't change. Age being big one. Gender. Stuff like that, genetics, things that we can't change, those personality traits that go down the road. All right. Some issues that we'll see cardiovascularly: hypertrophy of the heart, left ventricle gets thicker, fibrosis, where we end up seeing unwanted ligaments being formed, thickening of the chordae pulmonae. We end up getting hypertension, atherosclerosis, arterial sclerosis, overall decreased in that cardiac output. The aorta gets hard, just like that the internal intima of the venous as well as the arterial system becomes filled with cholesterol. It starts decreasing the size of the lumen. It becomes stiffer as well as it lengthens, and we start losing the ability to, react to changes in secondary distress, like sympathomimetically or parasympathetically. The ventricular pattern changes. Again, we end up having problems within the conductive system. We start seeing an increase in arrhythmias, possibly lethal arrhythmias. All that stuff causes problems, as well as I said earlier, secondary to neuro issues, sympathomimetics, drug usage, ACE inhibitors, all that other stuff causes our ability of the heart to respond to stresses. Please remember, as the stroke volume declines, the heart rate slows, we get a decreased cardiac output. Remember that. We'll come back to this several times, because a lot of what we treat, as I said earlier in this program, will come back to how we're able to alter this formula. Cardiac output equals heart rate times the stroke volume. All right. Try not to, it says here, don't walk a patient with cardiovascular complaint to the ambulance. Now, again, that's always taken with a grain of salt. If somebody wants to walk, there's too much anxiety. Boston EMS did research years ago that showed that walking a patient down a third-story brownstone down to the stretcher was a lot less evasive than trying to carry them down, because of the increase in the sympathetic tone, the release of the neuroepinephrine in that, because when you do that, you increase myocardial oxygen demand. But if somebody, you can't carry them or something like you're going to have to be able to get to a stretcher as quickly, stair chair them, or something like that. Patient, again, is hypoxic, using all of our assessment tools, whether they have technology behind them or it's the good old, let's listen with a stethoscope, or let's look at someone. They may need oxygen and an IV meds. Please realize that a lot of patients, a lot of patients may or may not take medications as prescribed, whether it be secondary to stigma with medication, as well as cost of medication or something like that. But depending on who the individual manage their PCP, whether they go to a specialist or PCP, each individual, based on their practice and their experience, they may end up having a different way of treating a certain complaint. So knowing what the patient's getting a good history and a good pharmacological look at is very important, because are these individuals that have previous cardiovascular issues taking anti-anginal agents? Are they taking nitro? Are they taking aspirin already? Have they taken diuretics, or are they taking diuretics? Are they any anti-arrhythmics or antidysrhythmics? Oh, they are. Have they taken them today? All right. One of the drugs that we also have to worry about are, especially with these anti-anginal agents, whether they be nitro or something like that, please realize that individuals, long-term males may end up taking some type of erectile dysfunction drug, some phosphodiesterase. And here's the big ones here. They all end in afil. Enafil, Avanafil, which is Stendra, that's a newer one. Sildenafil, the Viagra, the Tadalafil, the Cialis, and the Vardenafil, the Levitra, the Stiaxin, the 24-hour Viagra. Then we end up with the Cialis, 36 hours, Levitra, the Weekender, 72 hours. But please realize that just the ECD drugs are not limited to the male population. They can also be utilized by the females as well as males if they have diagnosis secondary to pulmonary hypertension. Notice here, sildenafil and tadalafil. They go by different names like Revatio and Adicirca, but they are the same exact drugs. They've just been modified. They've just been changed in their packaging to be able to treat other diseases. So if you have somebody that's on Ravato, you're not sure what that is, but they're said they don't take any ED drugs, but they take a pulmonary hypertension drug, you give them a nitro, then you got a problem. So you got to be familiar with what all these drugs do across the board. Note that these individuals, they'll have age-related doses. They'll have sliding scales, especially with the nitro. If somebody has angina pectoralis and they're told to take, up to 3 nitros Q5 minutes prior to calling 911, call them and, when you ask them, how many did you take? How many do you normally take? Where's your nitro been stored? Oh, it's in a brown bottle. Oh, right there on the windowsill. Okay, why don't we try one of ours? Because we know that stuff breaks down secondary to exposure to light as well as air. Vital signs rhythm, get an initial 3-lead rhythm, get 12 leads, get serial 12 leads. Treat them with respect, and you realize psychologically having a heart attack, an MI, is one of the most fear-inducing situations that can affect elderly people, because again, in their small circles, people die. Oh, did you hear about Harry yesterday? No, what happened? Oh, he had the big one, died of a heart attack. Oh, okay. So anxiety can be ridden. High anxiety rates can be very big on that. All right. In the nervous system, please remember nervous system, brain, and central spinal cord, as well as peripheral nerves, like cardiovascular cells, cannot reproduce once they are damaged and or dead. Now, that's not saying that in the future with stem cells and stuff like that, they can't rebuild them. But in general population, we're not going to see any regrowth of any cardiovascular or neurocells. Just because somebody's old, please don't think of them any less smarter than you. There are some individuals that are out there, despite the fact that they may have Parkinson's or something like that, something that may affect their neurological system, but does not affect their cognitive abilities. So never go into a call with that assumption. Some people may have difficulty with recent memory. I know, being 48, I can remember things that happened to me 40 years ago, 30 years ago, like they were yesterday, but I can't remember what I did 20 minutes ago. And words are starting to escape me too. When you hear me stutter step on certain things, it's very interesting. I'm quite aware of it, where I can see the word but I just can't get it to come out. Who knows whether or not, maybe had a TIA here and there, but it's very possible. And as you get older, you'll see that as well. Psychomotor does slow. We get older. It takes us, 20 minutes to get out of bed for snap, crackle, and pops to take over. We do become forgetful, and we have decreased reaction times in that. Remember, in cases of AMS or seizure, always maintain suspicion of trauma. Watch for that C-spine, but also make sure that they're not in a completely supine position. You want to maintain suction and secretion of anything else like that. Make sure you know what a good baseline is. And I know that's in a perfect world, but when we get these elderly patients from the SNF units or something like that, we'll get the nurses or CNAs that say, it's not my patient, they're just different from yesterday. That's always the hardest. But if we can know somebody's baseline, and that's where EHRs come in. If we can go back and review stuff, physicians can do it. Hey, they're not liking this. Having somebody who's a good moderator for that individual. Hey, this is what they can do. This is what they can't do. Really, really helps. Talk to the patient about certain things, communicate with them, ask them what they're thinking. Hey, because they may not understand the medical terminology and the education that you guys have, but you have to be able to talk it and bring it down to them. Ask their family members, previous caregivers, any obvious weaknesses, any new fatiguings, any sleep pattern changes, any syncope. And remember, there's simple syncope. Syncope is defined as a transient loss of consciousness for anywhere up to 5 seconds to a minute. And it self-resolves. They can be a predictor of later on CVAs. But again, what caused it? There's multiple reasons of syncope we'll talk about later. If you think that there's a stroke, go ahead and work them up. We have a lot of stuff at our disposal to be able to do that, but go ahead and do it. Look at blood pressure. There's not too many things that we can do in the field for a hypertensive crisis in our area, but there are a few, but be mindful of that. And again, if your patient at all you consider to be hypoxic, monitor them and treat them appropriately. Endocrine system, big ones that we're going to see here is diabetes, type 1 or type 2. Nowadays, they're called type 1 or type 2. You may see some literature where type 1 is known as IDDM, which stands for insulin-dependent diabetes mellitus, also known as juvenile diabetes. And in type 2 is the NIDDM, the non-insulin-dependent diabetes mellitus. Typically, that is treated with oral drugs, glucophage, metformin, but some type 1s as they go along may be developed and transition over to a type 1 where they do become insulin dependent. We can also have thyroid issues, thyroid storms, problems with that. Those are kind of known as what is known as clinical masqueraders, things that masquerade as something else. We'll talk a little bit about those. Signs and symptoms related to DM or thyroid issues may be absent or diminished. Again, this is the chronic side of this that we have to take care of, the life threat stuff. But again, you get to play the Sherlock Holmes when it comes to medical issues with these individuals. All right. Watch for cardiovascular when it comes to these individuals with the endocrine issues. They can go from everything's good into VTAC really quick if they end up having a thyroid storm with that. GI system gets all wonky as well. Saliva and gastric secretions may decrease, and with that then goes down their inability to hydrate as well as take in nutrition. Taste buds change, all that other stuff. We start seeing that production of hydrochloric acid in the chief cells in the stomach decreasing, gums atrophy, teeth fall out, that secondary to increase in cardiovascular disease. Hernias can have a lot of problems, especially in a hiatal type where we get stomach contents as well as the fundus of the stomach can actually come up into the thoracic cavity. We see decreased liver function as well as that tagged along with some type of disease state like cirrhosis can cause problems. And everything that goes along with these individuals, again, you may end up coming into somebody who's had a ruptured hernia, something is broken through, peptic ulcer disease has broken through the duodenum, and now they're hydrochloric acid, stomach acids that they did have in the stomach is now leaking into their mesentery area. They may only present to you with nausea, vomiting, and a little bit of peritonitis. There's other problems, again, that we can't really diagnose, but we should have a general idea, and we can rule that out by having, a good abdominal assessment. Thermoregulatory system, pineal gland, frontal issues of the brain. These individuals are very, very bad, or they can't naturally, through homeostatic processes, maintain heat or maintain their thermal levels. Therefore, they get too hot or they get too cold. They reduce because of the loss of sweat glands. They can't sweat as much. They decrease shivering. Therefore, they can't get warm. And then they have this diminished perception of cold. That's why you'll see most individuals, I'm really cold. It's 85 degrees out and not 100% humidity today, Nana. What do you mean? Those are all issues that go on. Integumentary system, we've all seen the old people in their skin. Because of the loss of collagen, vitamin D, stuff like that, as well as aspirin, anemia, a whole bunch of other things, the skin integumentary system of these individuals can become injured quite easily. And a lot of the elderly skin, due to the loss of collagen, doesn't doesn't lacerate, it actually tears, and we've all seen that, and we'll talk a little bit more about that going down, especially when we start seeing elderly individuals that are bedridden or in sedentary lives, where we start seeing breakdown and pressure ulcers with that. These patients, again, loss of dermal tissue, subcutaneous tissue, starting an IV is very difficult sometimes. The skin remains tented regardless of the overall water balance, and because of this overall skin breakdown, which is our first line of defense against bacteria and viruses and stuff, we see a high risk of infection, skin tumors, all that stuff that goes along with that poor integumentary system. Now, in prepping for this lecture, I've been looking at a lot of nursing care, because nursing, regardless of what people think, nurses got their stuff together, and they've got a lot of available things online. And one of the things that I started using, um, not only in my own learning, but also coming down, is drawings. So you're going to see a lot of in this lecture here, a lot of these memes. These little moments where this group called the Nursing Education Consultants, this is not original, and I tell you so, but instead of me, putting the title down for everyone where I got it, I'm just telling you right now, anything that you see in this manner has come directly from the Nursing Education Consultants, because I like the way that they're doing. They're able to put some cognitive issues in there with some cartoons, which we all like, and some treatment ideas. So here to remember some special considerations for dealing with the elderly, older clients. For a sudden increase in confusion, the big one is hypoxia. Why aren't they breathing well, or something like that? Also consider a UTI, just for the fact, especially if they have if they're catheterized in any way, whether it's a Texas catheter, whether it's an Foley catheter or something like that. Think of that. And then also, with electrical issues and all that other stuff, poor nutrition, look for electrolyte imbalance. Okay. But again, note everything that we just talked about, decrease tolerance to meds, decrease IV rate to avoid our fluid overloads. These individuals have a risk of respiratory depression, pneumonia, disorientation, skin breakdown, circulation issues, nutrition, constipation, fluid electrolyte balance, increase inability to maintain balance, as well as they fall down and go boom a lot. All right. Look at the overall, they've got so many different coexisting conditions, that cardiac problems, peripheral vascular disease, overall neurological disorders. All right. So these pictures bring a lot to us in one. Another thing that we need to talk about too is the perception that your geriatric patients and how they perceive you. One of the issues is vision acuity. As they get older, their peripheral abilities to sense the outside world changes, either vision as well as hearing. Hearing acuity goes down. They need their hearing aids. They may be deaf. They may end up having a cataract. They may end up having issues. They may have had LASIK 30 years ago. That's getting bad. They still need readers to see up close. They may need their glasses, all in all. So this is something to remember. What is a cataract, all right, versus what is glaucoma? Both of these conditions diminish the overall sight of the patient, almost to the point where they can become legally blind. But when we look at cataracts, basically cataracts is an overlying film of the lens of the eye. So here you can see the lens, and here's the cornea, but in between the cornea and right before the lens, a cataract will form. Now, cataract surgery is actually a very easy outpatient surgery fix that you just go in, and because there's no blood supply to the cornea in there, they can actually just slice that cataract out. As well as, if they do have to remove the cornea, they can do corneal transplants. And corneal transplants, unlike other types of transplants, do not require immunosuppressive drugs. These individuals that have that, because there's no blood flow to it, can get new cataracts. New corneas, and those new corneas do come from the dead. They are transplanted and harvested from those that have just died. So that's something to think about. Somebody just had cataract surgery; they have to wear blinders or something like that, but they're regaining their sight. With that, glaucoma, it's a condition that damages the optic nerves, secondary to an increase in pressure in the vitreous humor. With the funny fluid, the vitreous humor, which is the gel-like liquid that makes up the interior orb of your eye. And due to drugs, due to head trauma, eye trauma, as well as diabetes over time, what we'll see is a gradual increase in pressure in there. And as that pressure increases, the retinal, the optic nerve becomes compressed, and over time you lose the ability to see. So again, just glaucoma here. Risk factors for somebody to get glaucoma: genetic predisposition, over the age of 40, somebody who has a history of diabetes as well as hypertension, as well as history of ocular problems. And basically what ends up happening is people get this gradual loss. They get a tunnel vision. It looks like they're looking through a tube of cardboard that the paper towels are kept on with that. But again, doesn't hurt them, but it can cause problems. Individuals with their musculoskeletal system, as a person ages, they lose approximately 2 to 3 inches of their overall height. And that's because the intravertebral discs begin shrinking. If you ever want to think of the intervertebral disc and the vertebrae that sit on top of each other, think about Oreo cookies as being one top. The top of it and the bottom of it are the superior and inferior aspects of a vertebrae, but inside that white cream is your vertebral disc. Okay, it can swiggle around, but if you squeeze it too hard, what happens to it? It gels out. You can't put it back in. But when it does that, those cookie wafers come closer together. You get 36 of them crushed down all together, compression. Now you lose 2 to 3 inches. And that's basically what happens when individuals get older. We also can lose height secondary to vertebral fractures. Somebody gets compression fractures. They sit the wrong way or something like that. Causes problems. Osteoporosis, primary osteoporosis is caused by loss of calcium. Typically, you'll see Oscal being given. Older individuals being told to eat foods that are rich in calcium with that, because again, that calcium is being moved from the bones to the cardiac system back and forth as needed. We've already talked about the kyphosis, hip fractures, as well as the long bones, primarily are femurs. Somebody falls, somebody hit something, they have osteoporosis, those things, or even multiple myelomas, they end up having long bone fractures. We lose density of our skeletal muscle. And again, if we have anybody with musculoskeletal issues, give an IV, give them some pain control. Okay, do we need to give them an IV? No, we have ways to IM now, IN, all that other stuff. But again, look at the overall medical conditions, drug complications. Are they polypharmac? Any abuse or neglect in domestic or their home situation? And, what's their alcohol or drugs situation? Renal system starts shutting down. They start seeing a reduction of the overall functioning nephrons, usually decrease 30 to 40% from the age of 55. If they end up having renal failure, it's even greater. Because of this loss, we end up losing blood flow by about 40%. So with renal blood flow decreasing by 45%, instead of cleaning our blood every 6 minutes or so, a liter per minute or something like that, we're only going to see a quarter of that being cleaned in at normal time, which means these individuals are going to be building up toxins in their blood. So that's where we end up seeing dialysis, peritoneal dialysis, or something like that as well, leading up to full-blown kidney disease, end-stage renal failure, dialysis, and kidney transplant. All right. GI system, when we start looking at that, the genitourinary system, when we look at reproduction, stuff like that, please realize that most elderly individuals lose bladder, sensation, and tone. That's why you'll see individuals wearing adult diapers and undergarments with that. They may have a frequent need to urinate because the bladder decreases. They don't have as much muscle control over that. We'll see an increase in UTIs. Okay, patients become very, very septic very, very easily with this. In men, we have the prostrate gland. Again, remember the prostrate gland circles the ureter. The urethra, and as that becomes swollen or something like that, it shuts off urine flow from the urinary bladder out to the environment. And with that, because individuals do have problems with incontinence, and again, solid and liquid waste. Immune system, we see a general decline in the function of our T cells. That means we're opened up. Elderly individuals are opened up to a much wider breadth of bacteria as well as viral infection. We're living through that. We've seen everybody wear a mask to decrease and flatten the curve and make sure that grandma and grandpa don't get sick from this disease. Okay. Usually, as individuals get older, their vaccination titers go down. They're not getting enough adequate nutrition. They're poor on their infection control. They're not washing their hands a lot, stuff like that, and they're low in their exercise. As well as the elderly don't recognize and treat the diseases, perhaps. Again, socioeconomic, something like that, because they treat those alterations as life threats. Hey, you're threatening my lifestyle. You're doing something like that. We also want to prevent exposure to infectious agents that are very susceptible to something like that, as well as we want to take these necessary precautions. We're doing that now in the COVID-19. Now, I put this slide in here just because it's under the immune system. We are living in now, as Jerry alluded to earlier, we've been doing this a long time. And for me, this is a 30-year career. And when I started in my career in 1989, the AIDS epidemic was full bloom, where everybody was afraid for everything, everybody getting AIDS. And again, AIDS stands for acquired immune deficiency syndrome. The virus that causes AIDS is HIV, the human immunodeficiency virus. Back in the early 80s, when someone was diagnosed with HIV and or AIDS, it was pretty much a death sentence. But we're seeing individuals now living through these with medical technology, drugs, antivirals, and all that other stuff. We have individuals that that were originally given 3 years to live are now living 30 years. And Magic Johnson's one of those individuals. So please be mindful when you're out in the field. You may end up seeing someone that is diagnosed with AIDS somewhere along the way. And again, proper PPE and everything else like that limits your exposure to that. But please realize that, there are individuals out there living with this syndrome now, as well as you also see individuals that have a immune deficiency issue. While AIDS is an acquired immune deficiency syndrome through a virus, please realize that there are individuals out there that have immune deficiency syndromes. Every patient that you will take care of that has had a major organ transplanted are immune deficient because they're taking medications to decrease that immunity with that. So just be mindful as things go along with that. One thing that you also see is there is something known as AIDS dementia complex, where individuals, now this usually occurs much, much earlier in AIDS, but in the age, AGE, how old someone is. But please realize that you will see cognitive, motor, and behavioral impairments in individuals, but this may be masked if they do have AIDS as just normal progression of the pathophysiology of sentience of getting older. Hematologic system, again, you're going to see a lot of patients that are anemic. You're going to see a lot of individuals with thromboembolic events, PEs, CVAs, DVTs, stuff like that. Our the blood volume decreases because is our blood formed? All right, in the long bones, in the caverns of the long bones. With that, so please be mindful of that. Pulmonary respiratory disorders. Okay, these are, this is what we're going to see here, and I'll go through one here when we look at this diagram here. What can cause shortness of breath of patients? It's a big issue. Could it be cardiac? Of course it could. Could it be purely respiratory? Yes. Could it be bacterial? Yes. Could it be viral? Yes. Could it be toxic? Yes. But these patients that complain of pulmonary and or respiratory disorders are going to have complaints of coughing, shortness of breath, congestion, potentially wheezing. When did you lose sound, Lorenzo? Okay. All right. I dropped my headset. That may have gone off. All right. So, as we said again, pneumonia can be viral or bacterial. You know what, guys? I just realized I've been doing this for an hour. Why don't we go ahead and take about a 9-minute break and come back here at 8:40. All right, everybody, it's 8:40. Can everybody hear me? All right, I apologize for that. I've got this little mute button on my cord going back, and apparently it did hit the side of the desk and clocked and logged off. So I apologize for that. So let's get back into this. A lot of stuff. But again, we talked about pneumonia. There's not much in the field for us to be able to do. Identify it, maintain ventilatory status. Please realize that individuals that do have pneumonia may end up also be suffering from dehydration due to fever or not feeling well, so they could benefit from a little bit of fluid. The treatment for trying to figure out whether or not it's bacterial or viral cannot be done. There used to be an old wives' tale: if something was green versus brown, you could tell if it was viral versus bacterial. But again, that was an old wives' tale. But we want to, they need to go to the hospital, get sputum counts. They want to be able to get blood draws and get cultures and everything else like that, and start on wide spectrum antibiotics until they can actually figure out what the bacterium or virus is in there. So majority of this for the pneumonia is going to be secondary to maintaining homeostasis of the respiratory system, giving them O2, perhaps positive pressure ventilation, CPAP, giving albuterols, getting duonebs, terbutaline, maybe sub-Q epis. Okay, because again, basically what we'll see on X-ray is most pneumonias like to go to the lowest point, which you'll see them in basilar lobes, but there are some times that may float up and get into the apexes or the middle lobes or something like that. But again, it's this exudate, whether it be viral and or bacterium, is going to start dumping fluid in there, thereby closing off the oxygen and CO2 coming in. Lung sounds are going to be extremely thick. You'll hear them when you listen. Very rarely, possibly with some wheezing, but the wheezing, may be a little bit higher too. So that's why we end up getting the duonebs to end up opening up whatever's in there, because the albuterol isn't going to clear away. It may loosen it up, and then they end up having this productive sputum with that. But it's a combination of everything that goes along. But with the pneumonia, we'll see people becoming very frail. Community, they'll become compromised with their immunity. Individuals who are institutionalized, whether they be in the jail, whether they be in SNFs, those individuals are highly vulnerable. We'll also see that when it comes to TB as well. But individuals will complain of shortness of breath, chest congestion, maybe a sore throat, fever, chills, tachypnea, overall increase in sputum production, altered mental status as things get worse. And again, as we talked about, manage the life threats, give them adequate oxygenation in whatever manner that you need to see. And here's a nice little review of what's going on. Typically with pneumonia, we'll see a temperature in excess of 102. We'll see, we'll grab, in the ER, they'll grab a sputum specimen. Okay. Diagnosis, culture of sputum, chest x-ray, ABGs, as well as VBGs. They can get the venous blood gases as well. But again, could be yellow with a productive cough, could be yellow, could be blood streak, could be rusty with that, different colors, okay? Some opportunistic bacterium in there could be what's called pneumocystis, carine, pneumonia, Mycobacterium avium, the complex form. Also, you will see, as we were talking about earlier with the HIV and the AIDS patients, you will see a high incident in that population of pneumonia. So that's something to think about as well. COPD, chronic obstructive pulmonary disease. It's a general term that encompasses a whole bunch of different disease processes, but they all lead to a chronic obstructive pulmonary issues, because the chronic airflow is obstructed. And it can be either reversible or irreversible, like when we talk about bronchitis, inflammation of the bronchioles, typically usually bacterial or viral component, that's reversible. Whereas if you end up getting emphysema, okay, or lung cancer, and you end up having to have a lobectomy, obviously that is irreversible. Asthma is another one of those reversible issues. 80% of these, according to some research that I did, is caused by cigarette smoking. With that, down the road, and I'll show you specific cases very near and dear to my heart, when it comes to the majority of the disease process was secondary to, and ultimately the mortality was secondary to cigarette smoking. Please note existence of childhood respiratory disease. Please note that children of parents who smoked also suffer COPD later down the road as they reach adulthood. That's true of me. My mother smoked 4 packs a day for 40 years. Most of those 40 years I was at home. That led me to have asthma, as well as other issues that are directly related to now to heavy smoking. Again, exposure to environmental pollutants and a genetic predisposition will lead to that. But when we start looking at COPD, we could see various things going on due to an inflammation of the airway passages, whether it's secondary to asthma, emphysema, chronic bronchitis, or something like that. We'll see, because of that decrease in airflow, we'll see reduced oxygen exchange, therefore hypoxia, as well as hypercarbia. We'll start seeing these individuals having increase in accessory muscle usage, pursing of the lips, nasal flaring. We'll end up having retractions of the intercostal spaces. Coughing is a very big form of air hunger. You'll hear if a COPD will be coughing, yes, they may have a tickle in their throat, but it also brings in a lot more oxygen. Dyspnea on exercise or not, can't tolerate long-term exercise, do have an increased sputum production, may have pleuritic chest pain, pursed lip, tachypnea, tripod wheezing. Okay, here's another little thing with COPD. Okay, emphysema, chronic bronchitis. Here we see these individuals, on oxygen, and this flow rate could be anywhere from 2 to normally 6 liters, but we'll also see incidences now, especially if somebody is hospitalized, with high flow nasal cannula up to and including 60 liters per minute. These individuals, as you can see, he's standing on a dinner tray here, leaning over, putting his chest over his pecs, which allows gravity to assist, pull that open to breathe. Okay. Prolonged expiratory time. They got to blow out because they're trapping air in there. Card pulmonale later on, that's right-sided heart failure. They look thin. They look wasting. You also see digital clubbing. Typically, if you've ever seen a smoker over time, or somebody that has long-term COPD, you actually see after the last flange, or that first flange on the knuckles, you actually see them start clubbing their fingers out, where it becomes flattened and wider at the base of the fingernail. Versus your individuals with chronic bronchitis, these blue bloaters. Okay, here you can see the dinosaur here again is on O2. You've got smoking. Okay, but with these individuals, they look a little blue. They have this constant cyanotic lip look to them with the chronic bronchitis. Recurrent cough, sputum production. Because of the disease process, they're constantly hypoxic, constantly hypercapnic, have acidosis, and they're edematous on that outside. They're on that typically right-sided failure. Increased respiratory rate, exertional shortness of breath, increase. They see an increase in chronic bronchitis here with the heavy smokers, cold pulmonale, overall cardiac enlargement, because all of that pulmonary hypertension that's building up is causing that right side to have to overpump to get the blood through the pulmonary system. And here we see these individuals needing the accessory muscles as well. This one's a little bit unclear. I apologize. We get the emphysema, the pink puffers. They're usually very red. still cigarettes, but this tends to be, they have friction down in that alveolar diffusion. They hold in a lot of CO2, okay, because their alveolar membranes start to shrink. All right. These are the guys and girls with orthopnea. All these patients have orthopnea. They lay down and become short of breath. They get to barrel chest. They have exertional shortness of breath, prolonged expiratory time. Because again, they're trying to force all that CO2 out of that area. They look anxious. That anxiousness comes back to that shortness of breath and that hypercapnia. Now this picture here, I will tell you, is my mom. And again, my mom passed away last May. This picture was taken on the Sunday, which was 3 days before she died. She died on a Wednesday morning. But my mom was a heavy smoker, 4 packs a day. My mother also had 4 bouts of lung cancer. She also, about 15 years prior to this picture, she also had a partial lobectomy on the left side that took basically half of her lungs. So she was working on one and a half lungs. My mom is this, and the reason why I took this picture and I decided to show it to you, this is here she is in hospice care, and here she is on high flow nasal cannula. My mom did not die secondary to cancer. My mom had cancer. She had beat it several times. But what happened was my mom died secondary to exacerbation of her COPD. Her lungs had shut down. My mother could not breathe any less than 60 times a minute. Very short, choppy breaths, could not exhale. But this high flow nasal cannula was at about 60 liters per minute, and it added about 10 to 15 cms of water of PEEP. As she succumbed to the exacerbation of the COPD, my mom was not only on this device, but she was also on a CPAP device. Just trying to get, even at home, my mom had rigged up with respiratory therapy, had rigged up 2 to 3 concentrators that flowed for about 30 liters per minute. With that. But again, my mom did not die secondary to the lung cancer. She died secondary to the progression of her COPD, which ultimately led her in an acidotic environment, led her to recurrent pneumonias, and all that other stuff. My mother also had issues, the hyperthyroidism, Crohn's disease. My mother was also an alcoholic, so these are all things that we see when we take care of these elderly patients and have chronic disease states. Another one I wanted to bring up, while not included in the COPD, it is what is known as an old world infectious disease. It's tuberculosis, and there's a huge recurrent of TB, especially in the institutionalized, the SNF, the immigrant population. But TB is very nasty. The majority of TB tends to be bacterial. It actually forms in little cysts, and basically what happens is you end up getting it. It's transmitted via airborne, in droplet fashion, and it goes and finds the following into the bottom of the lungs. Typically, these individuals will be. It used to be known as the wasting disease, where you get progressively fatigued, you suffer from malaise, you suffer from anorexia. Chronic cough becomes productive over time. You end up suffering from night sweats. You end up having hemoptysis, blood in the sputums. End up suffering from pleuritic chest pain, and you end up getting these sundowner, low-grade temperature. Now, TB is curable, but we're seeing a lot of TB that tends to be antibiotic resistant. Here, treatment typically is you take TB meds 6 to 12 months, 3 times a day, and usually it's for non-restrictive. It's 2 meds. But you can actually, the institutionalized stuff becomes so resistant to antibiotics, you're taking 3 or 4 drugs a day. you decrease your activity, you end up being in isolation until you have a negative sputum, but you're frequently sent out on an outpatient patient. To diagnosis, typically you'll have a TB test, also called the MAN2. This is why everybody that comes into medical school, medic school, anything has to have a TB test. If you test positive once, that means you have the antigens in your body, and you end up having to have annual chest x-rays, which is in my case. I tested positive at age 13 with a skin test for TB, had to go to the health department for at least a year, took rifampin and something else, a 2-year, caused liver damage over that, but I couldn't do it. And the reason why I test positive was my grandfather had TB when he was in World War II. He was a cook on a destroyer in the Pacific, close institutionalized environment, ended up becoming TB positive, and I hung out in my early years with my grandfather. But it's something to think about. With the COVID issue, we're going to see a lot of changes to PPE, and in a way, taking care of TB, a lot of people are don't know that they have TB for many, many years. So they can be infecting a whole lot of people. But it's one of those things that's out there. It has been out there. It's kind of been wiped away from the psyche for many, many years, but we'll see a resurgence of it coming up. The other thing is you can get TB in cutaneous forms as well. It is just as infectious, but a lot of people don't think about that because it is weird. But once you see a TB cutaneous infection, you'll never forget it. Talked a little bit about asthma, reactive airway disease. Again, it's a form of COPD, but usually asthma is physically induced with exercise, can be triggered secondarily to other infections, viral or something like that, air pollutants, environmental, cat dander, all that other stuff. GERD, gastroesophageal reflux disease, because the acid will come up, trigger the cough reflex, which then triggers you to start breathing heavy. You get that rush of norepinephrine. Things don't work as well. You start coughing more and more and more and more. You'll end up seeing hypoxemia with these patients over time. They'll become tachycardic. They'll get increased anxiety and restlessness, tachypnea. Usually most asthmatics are very well regulated. We carry our own albuterols. We take care of our Advair. We know what our triggers are, but there are the young ones. And again, don't forget anaphylaxis can also lead to a severe status situation. That's going to be terbutaline. That's going to be EPIs, IM EPIs, duonebs, albuterols, stuff like that. But again, it's a life-threatening issue with the asthma. And ultimately, if you ever take care of an asthma patient, especially an elderly, ask them if they've ever been intubated. And if it does get this bad, if it does get worse, do they still want to be intubated? Questions that you need to ask your patient. Another thing that we're going to see potentially with the elderly, most of the time pneumothoraxes are discussed under trauma, but I wanted to put it in here just as a respiratory issue. Because if you get the asthmatic, you get the COPD or anything else like that gets a bleb in the bottom right there where it says a ruptured bleb at the base of something, you can end up having a spontaneous pneumothorax. Treatment for it is just as we learned in the traumatic role. If they end up becoming, midline movement, if they end up having hemodynamic instability. But again, it's one of those things that you need to be aware of, that all of these non-traumatic issues can lead to a pneumo. So be mindful of that. And as all of this stuff all comes together, has implications in overall hemodynamic stability of your patient, because again, whether somebody is hypoventilating, therefore becoming hypercarbic, we're going to become acidotic. Okay, DKA, some other stuff that we'll talk about. But again, we start slowing that breathing down, we're going to become acidotic. If we start becoming tachypnic over periods of time, we're going to go the opposite way, or we're going to become alkalotic with that. So that's something to think about. And then up there in the left-hand corner, you'll see there's the 6 P's of dyspnea. What can be causing things? When you look at it, do they have a possible foreign body? Did they, not swallow something? Again, that's mostly younger kids, but can it be, somebody with dentures, don't have sharp enough teeth? and can't get steak all the way down, there's an issue. Okay, do they have bronchial constriction, whether it be from asthma or something like that? Do they have a PE? Do they have a pneumothorax? Do they have a pneumo? Do they have a pleural effusion? Anything else like that? Or are there cardiac considerations with this? So a good assessment head to toe will help you try to figure out and treat your patient appropriately when it comes to all of this stuff. So PE, again, PE is pulmonary embolism. It is a blood clot, a thrombosis, an embolism that has broken free from someplace in the body, usually located in the lower extremity, secondary to sedentary situations, and it floats around. Other causes for that could be AFib. AFib was, new onset atrial fib. The atria are fibrillating. The blood is repeating itself. It becomes coagulated. Now it breaks free. Now it floats around, ends up going into the smaller pulmonary trees, and it gets stuck somewhere. And that's what's going on. DVTs, fractures of pelvis, they can form from there. Think about PE. If you ever take care of somebody that's had up to 7 to 10 days post-op of having some type of surgery, and they get crushing chest pain, pleuritic pain, can't maintain saturation, shortness of breath, consider a PE, especially in the younger individuals too, females taking birth control pills, amniotic embolism, stuff like that. Individuals that are obese are at a much higher rate. Individuals that suffer from paralysis, the lower extremities. Again, they're not moving around. Long over-the-road truckers, individuals that sit for long periods of time. You get somebody that's on a 12-hour flight across the United States into Australia, and they don't get up and walk around. They get off the flight, and all of a sudden they develop shortness of breath. 9 times out of 10, PE. Do they have a venous catheter, indwelling catheter, like a PICC line or something like that? Trauma, the leg vessels, and we talked about the birth control. But basically what happens is it breaks loose in this area. We've got a DVT, somebody's not moving, up, walking around, okay? Venous stasis, this starts floating around. Next thing you know, it comes up through the right ventricle, out through the pulmonary valve, and goes out to one of the pulmonary arteries and goes out to the lung, and it gets stuck. Okay, it's like a tennis ball trying to go through a hose. It just gets stuck. You have blood flow up into that point, and then it stops. And over time, that the upstream version of that, the lung isn't going to get any blood. Therefore, it's going to become hypoxic, as well as if it's a large enough vessel, enough blood doesn't come back into that left atrium and left ventricle. Therefore, our preload is decreased, and we now had increased pressures, pulmonary hypertension, all that other stuff. So with this, we can look at it a little bit on a if we know what we're looking at in the chest leads, we can see a little bit if it's a right-sided or left-sided, but the true diagnosis comes in from pulmonary angiograms, MRIs, VQ scans, as well as a dimer test. We can actually see that. Most of the time, treatment for us is going to be end up being supportive in nature. If they're having chest pain, we try one nitro, it's not really working. We start thinking, going through their history, what's going on? Oh, you got hit by a car. In fact, last week, I don't know if you guys know who Vic Henley was. Vic Henley was a 57-year-old comedian up in New York, and about 2 weeks prior, he was walking across the street and he got hit by a car. He fell down. He said, no, I'm fine. Didn't go to the hospital or anything else like that. Commented the idea, you've been urinating blood for a couple days, this, that, everything else. Started having chest pain, showed up to the hospital. They didn't realize that he had a PE, and he ended up dying, last Sunday or something like that. So this stuff, if we're on their way in and potential with that, it can lead to cardiac arrest. But once they're in the hospital and they're able to figure it out, they can get a Green Springs filter. They'll get if they're not actively bleeding somewhere, most of the time they can treat it with fibrinolytic therapies, as well as Warfarin and all that other stuff that goes along with it. And here's just another view of that same picture, where down here in the pulmonary arteries, we end up getting this embolism that is stuck there. Now, please realize the difference between a occlusive stroke and a pulmonary embolism. is basically where the clot has ended up. That could have also ended up in your LCA. It could, if you have a DVT that breaks through or something like that, please realize these embolisms, depending on where they come to rest, can cause various problems, from heart attack to stroke to PEs. We've already talked about all this stuff. Basically shortness of breath, cardiac arrhythmias, cardiovascular collapse, cardiac arrest. But that's how everything goes. Risk of death is greatest in its first few hours. Okay, getting them to where they need. But monitor skin color. Look at the extremities. Realize that an individual that has a DVT in their lower extremities, you always check the calf muscles. Do they have good pulses? Do they have good color? Are you sure the calf doesn't hurt? Pulse ox, capnography, as well as rate and rhythm for their breathing. Pulmonary edema can come from many, many, many reasons, whether it is secondary to right-sided failure, left-sided failure of the heart. But basically what we get into is pulmonary edema is fluid in the lungs. Okay, it can be a pleural effusion where you end up getting something outside of the lung tissue. A pleural effusion basically is like a hemothorax, only without blood, where there's fluid and or pus, purulent discharge outside of the lung tissue, versus what's on the inside. But when we get that pulmonary edema on the inside, typically we're talking about what is actually lining in the alveoli. All right. So when we look at left-sided failure, and the next one, which will be right-sided failure, but left-sided failure occurs because the left side of the heart, the left ventricle, is unable to pump out the requisite amount of cardiac output coming out of that left side. Blood is backing up, secondary to pulmonary hypertension, some type of PE, or something else in there. MI. So basically, what happens is the body does not get enough fresh oxygenated blood coming up and out. So that fluid starts being backed up into the pulmonary system, which leads to cyanosis, which leads to lung fluid being osmotic pressure changing between the pulmonary capillaries and the alveoli, where water starts, the plasma starts being pushed out. And that's where we end up getting individuals that have pink frothy sputum. With that, cyanosis to the extremities, because we're not getting oxygenated blood out of the left ventricle in a good enough time. Paroxysmal nocturnal dyspnea, meaning shortness of breath stops and starts at night. They can't lay flat. They have to sit up. They got to be in tripod. Okay. Patients are going to cough on us. They're going to cry. They're going to have crackles, rales, and wheezing. Maybe blood-tinged sputum. They become tachypnic. Exertional dyspnea, tachycardia, orthopnea. Heart rate, again, that tachycardia is going to be 120, 130. You may end up seeing, if it goes on long enough, may lead to VTAC or SVT. Confusion. And again, they may be breathing, they may be diaphoretic, okay, but the confusion secondary to the tissue level being hypercarbic. When we look at that right-sided failure, we end up having the preload coming in. The lungs can't handle it on the right side of the heart, so things start to back up. We have an increase in peripheral venous pressure. Left side still pumping up and out, pumping up and out, pumping up and out. But what we end up seeing is the extra fluid, that plasma and lymphatic fluid, starts to find areas of gravity and starts to pull there in the lower extremities, in the legs, in the lumbar region, in the stomach, in the liver and spleen. We also see, because we have that increased venous pressure, these are the patients when laid at 45 degrees will actually start seeing JVD, jugular venous distension. That means that right side of the heart can't handle the pressure. All right. With that, and typically this is slow. Right-sided failure, pulmonary, is over time. Left-sided failure can become flash pulmonary edema. This right side takes a while. Treatment for this, honestly, is going to be, once they figure it out, if it is that right-sided, controlling the hypertension, decreasing that venous pressure. This may be a right-sided MI. This may end up being, let's give them a little bit of diuretics. Let's do a right-sided EKG, 12-lead EKG, and try to figure out where this is coming from. Give them the O2, monitor all that stuff. Put them on the monitor. Give them an IV. You may not need to give them any fluids, but you may need to give them some drugs to help reduce some of that water weight. These individuals, typically, if they're not up and walking around, these are going to be your patients that you get to the ER, they cath them, and then once they do chest x-rays and rule out that it's not pneumonia, then they end up giving them Bumax, Lasix, some type of diuretic. So it becomes interesting on that. And this is just a nice little picture I like because it shows what is preload and what is afterload. And with all of that, how that ultimately affects our cardiovascular and our respiratory systems. And again, there we go, our cardiac output. Cardiac output equals heart rate times stroke volume. All right, and it comes down to all this. All right, lung cancer, one of those respiratory issues, diseases. We'll see a lot more people, especially, the smokers, the caustic breathers, stuff like that. But basically what lung cancer is secondary to a metastatic tissue of our own type. This is, please remember, cancer is not a weird invader. It is our own tissue that has gone via mitosis and is a DNA issue somewhere along the way. It's been exposed to some type of carcinogenic, and again, breathing stuff in can cause those cells to get all wonky, and they just grow without boundary. And basically what happens is in lung cancer, that cancerous tissue, that metastatic cancer, okay, or even if it's just a tumor, takes the place of the good lung tissue. It displaces it. So therefore, all of this cancerous mass in this picture next to the lymphatic system here doesn't exchange oxygen, doesn't allow CO2 to be expelled out of the system. Therefore, that patient, just by default and their pathophysiology, despite the fact that we're giving them all the oxygen in the world, that upper left lobe probably does not ventilate very well. But that's basically what cancer is. With that, some people view it as a virus and everything else like that, but again, it's part of your body. And a lot of the therapies that go into treating cancer now initially are immunosuppressive, because they want our immune system to actually turn and attack itself. And that's one of the hardest things. So typically what they'll end up doing is using chemotherapy, which is drugs that go and attack and destroy that tissue. But the problem is with chemo is it destroys all the tissue it touches. And then radiation is specific radiation aimed at that mass to try to burn it away with radiation. Cardiovascular disorders, again, are going to be one of the leading causes of death, according to the CDC in the United States. With that, it can be a cornucopia of issues and signs of symptoms that go along, and you guys could read along with this. But again, hypertension may be orthostatic, where they lay down and they become hypotensive. Angina pectoralis. Angina pectoralis is angina-like signs or symptoms, chest pain, that come and go, that are easily treated secondary to vasospasms, and they're treated with nitroglycerin. Individuals that are having diagnosis with angina typically are individuals that have already had an extensive cardiac issue. Typically, most angina patients are told by their PCPs or their cardiologists, hey, guess what? You get this chest pain all the time. There's nothing we can do about it. Before you call an ambulance, give yourself 3 nitroglycerins over a total of 5 minutes each, 15 minutes. If the pain does not go away by then, or it's reminiscent of an MI, call the ambulance. So most of the time, angina is due to vasospasms, whether they're exercise-induced, stress-induced, cold weather-induced, or something like that. But usually it's transient and it resolves on its own, or with nitroglycerin, maybe a little bit of O2. We've talked ad nauseum with MI. Heart attack and basically an MI is death of the muscle tissue. We can have partial tissues. We look at them on EKGs, everything else like that. Females typically present very differently. Individuals just may, female individuals may have periods of syncope or something like that. That's why all those patients should end up having a 12 lead done just for diagnostic sake to make sure everything's good. Shortness of breath, common in patients over 85, and most of these patients have exercise intolerance. So here's another one of those things. Patients can present themselves in many, many ways. Pain typically is onset, usually substernal, right underneath the sternum. They can define it as a crushing, a tightness, can be severe at times, usually unrelieved by nitro, as well as positioning. It doesn't change with positioning. If we end up getting positional changes, it could be pulmonary related, it could be pericarditis, endocarditis, something like that. Typically unrelated by nitro, but we have to be careful with the nitro. May radiate to the back, neck, jaw, shoulder, arm, as well as end up having some nausea associated with it. Usually there's shortness of breath with it. We'll see possibly some type of syncopal episode secondary to hypotension, nausea, vomiting, extreme weakness, diaphoresis, denial. One of the big things, no, I'm not having a heart attack. I'm not having a heart attack. Increase in heart rate, definitely tachycardic secondary, maybe not from the myocardial oxygen demand, but secondary to the anxiety that goes along with it. Okay, O2 treatment's going to be O2 IV medications, and in that too, if we have arrhythmias, anything else like that. And then they talk a little bit about here dietary restrictions with that. But again, some bunch of things that we're going to see in these individuals with MI. They will end up having fatigue and weakness, neck, dental pain or epigastric pain, syncopal issues, again, stress, exertion, stuff like that. And it does have a high mortality rate, especially once you get above 65. So the old adage is, treat somebody as if they're having an MI until you can prove otherwise. We've already talked about heart failure when it comes to the MIs and all that other stuff. But again, please be mindful, right or left-sided is possibility on any patient at any time. And depending on how much heart damage they have, you can have both right and left-sided failures. Those are always the fun calls where they need fluid because they're hypotensive, but they're already backing up with CHF. So that's where it becomes very, very, very problematic. That's where you may end up having to use that dopamine and figuring out those drips, or if you work in a system that has dobutamine or something like that. Or you may end up having, you can't get the heart rate up, can't give them fluids, all that. Hey, let's try to pace them. So you got to be able to draw from that toolbox. Some other issues with this, patients are anemic. They get old. They're not, the hematocrit numbers are down. They may have new onset arrhythmias, dysrhythmias, or secondary to previous cardiac injuries. They're suffering from hypoxia. Please remember, when you have problems, whether it's left or right side, please remember how is shock defined? Anybody remember how shock is defined?
Yeah. Inadequate perfusion to the extremities.
Well, not even the extremities, Sam. Okay. It's inadequate tissue. And again, it's if the heart's not getting blood around, okay, they're not getting oxygen. That's defined of hypoxia. So giving them some oxygen is not a bad thing. And again, we don't need to go overboard. Keeping that around 94, 95, as long as there's no pre-existing, like what if they have carbon monoxide poisoning? You want to go get the patient that has crushing chest pain, but it was happening as his flu was bad on his furnace. Well, he's also got CO poisoning. Guess what? That CO reading is going to give you off pulse ox. So you have to be able to use the technology with your assessment skills. Okay. Other things when we start getting into this, please realize noncompliance with drug therapy. I can't tell you the number of times that I showed up to a patient's house and they were in VTAC, secondary to, they said, oh, no. And when I dig in a little bit more, they haven't been taking their lidocaine or their AMI or something like that. Oh, well, why didn't you? Well, I didn't think I needed to. Well, that's why your heart. And we'll talk a little bit more about seizures, why individuals have breakthrough seizures. Well, I didn't think I needed, I haven't been having my seizures, so I didn't think I needed to take my Depakote. Well, do you realize that you were taking your Depakote was why you weren't having your seizures? So sometimes that educational concept doesn't go along there. Some other things that go along with these MI issues and these cardiovasculars and things that we're talking about here, this heart failure side, thermoregulatory disorders, with the thyroid diseases and everything, this can add to this. Taking NSAIDs. NSAID every now and then, okay, but they're finding out with a long term, it can cause problems. Fatigue, we end up having that left failure. Individuals have two pillow orthopenia, meaning they can't lie flat at night. Shortness of breath on exertion, and we talked about the paroxysmal nocturnal dyspnea. But again, these heart failure patients, dry hacking cough, okay, dependent, if they end up having edema, again, external, that peripheral, you're going to see that consider right-sided failure, okay? Do they have nocturnia? Do they get up and urinate a lot, okay? Anorexia, hepatomegaly, and as well as ascites. Now, along with the hepatomegaly and the ascites, we tend to see portal vein issues as well as liver issues. Arrhythmias. What more do we need to talk about arrhythmias in the cardiac conductive system? It covers everything, especially with the elderly, on everything that we've talked about. All right. But regardless of all this, these arrhythmias can lead to cerebral hypoperfusion as well, lead to TIAs, can lead to syncope. So be mindful of that. Patients also may have pacemakers, and again, pacemakers fail. The batteries are usually good for about 10 years, but they may have a bad one or something like that. You can end up having fibrosis around the catheter site, which actually causes it to pull the catheter away from where it was implanted into the ventricle or into the atria. You can also, car accident or something like that, or some type of trauma can fracture one of the leads on the pacemakers, which now patients, has runs a VTAC, and then all of a sudden, my internal defibrillator starts going off multiple times, so there's a lot of issues that can go along with that. Aortic dissections and or aneurysms. Basically what happens with a dissection of the aorta is that the wall of the aorta becomes very, very thin. It becomes arterial sclerotic heart disease. It gets very hard and it fractures. Typically 80% of thoracic aneurysms are the result of atherosclerosis as well as hypertension. Those walls become hard, they become cracked very easily, and then you dump in hypertension, 180 constantly, 180 systolic constantly, bang, it blows. If you want to, there's a very good Khan Academy video, it's about 15 minutes long, that goes through the detailed patho of aortic dissection. Now, there's typically three types that we worry about. We have the ascending thoracic aorta, which is on the ascending portion of the aorta coming off that left ventricle. Then we end up having the descending portion of the thoracic aneurysm that goes down into the diaphragm, and then we end up having the abdominal aortic aneurysm. Typically, you're going to see that the ascending, the TAAs here, the thoracic aortic aneurysm, whether they be ascending or descending, patients will complain of a ripping pain going on in their thoracic. Most of the time, it's trauma that kills people. This is what happens is that arteriosum ligiosum in that area gets ripped off and they bleed out into their chest. Literally, those patients do not survive. They don't have a chance in hell unless they're literally opened up already on the OR table and they can cross clamp it. Most of the time, these patients feel like they're having a heart attack. Next thing you know, they tear and they literally, within 3 heartbeats, are dead in your hands. The abdominal aortic aneurysm, whether it's a fusiform, which is the entire diameter, or just a saccular aneurysm, which is just one side or the other, this is why we check our abdomen, is to make sure that we don't have a pulsating mass in there. Most patients, again, if they tell you that it feels like in their thoracic or abdominal cavity that they have a tearing sensation, that should set off your spidey sense, that should set off your phone, your Fitbit, whatever electronic device that you're looking at, and say, ding, 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 there's something going on. Oh, do you have hypertension, ma'am or sir? And then if you when you transport them individuals, those individuals are transported with kid glove care because they can sneeze, they can cough, they can fart the wrong way, and that could open up. Most of the time, these individuals may or may not know about it, but it's something that, again, you want to think in the back of your head, oh, really? And if that please realize if you do have considerations of a diagnosis of some type of aneurysm, you want to watch your blood pressures. Yes, you want to start a large bore IV because they're going to end up needing blood somewhere along the way. But you don't want to send them hypertensive or get their blood pressure. Permissive hypotension in these potential cases, if you're doing an interfacility transport on these or something like that, ask people, what do they want their pressure to be? Because you don't want it too high. Because if you get it too high, there's a possibility, as well as if you give too much fluid, you end up with, diluting the clotting factor as well as increasing the pressure, which can then lead to a aneurysm in that. All right. Going backwards, sorry. Another common case that you may want to be aware of, I've seen it on the registry twice, about Marfan syndrome. Marfan syndrome is a syndrome which is caused by abnormal growth of tissues and dilation of the root of the aorta, which leads to, later on in life, the potential for a ascending aortic aneurysm. But as well as in the descending and abdominal. Okay. Usually the pulses in the legs are diminished or absent secondary to issues like that, but that can be from a leaking abdominal aortic aneurysm, as well as these individuals with Marfan have sensory abnormalities. They tend to be very, very long. As far as their extremities, with that, long faces. If you've seen somebody with Marfan, you've seen them. You know what they look like. We've talked about hypertension. Hypertension is diagnosed as someone who has a blood pressure greater than 140/90 over 3 consecutive blood pressure readings. Typically, they'll do them over time and look at a trend, but that's something that becomes problematic. But over time, prolonged hypertension can lead to heart, brain, as well as kidney failure. With that peripheral vascular disease, typically you add that together with diabetes, that leads to stroke, that leads to MIs, and all those issues. When you look at cultural and racial issues when it comes to divvying up hypertension, you will find that the African American community has much, much higher rates of hypertension than other communities. The other one that has very low on the opposite is Asian. In one, there's a genetic predisposition. In two, dietary. Typically, the African American diet is high in fat, high in animals. Proteins, whereas the Asian community typically is vegetable based. If they do eat meat, it's mostly fish. So rule that stuff out. Hypertension, again, some prevention. You see old people, they want to be on a low sodium diet, have them exercise, quit the smoking and or vaping, and make sure that they're compliant with their medications. Hypertension is that silent disease. You live with it your whole life. I got diagnosed with essential hypertension at age 13 when I passed out with a blood pressure of like 260/150. I started taking hydrochlorothiazide, HCTZ, at age 13. Nothing I could do about it. I've tried exercise, I've tried diets. I am obese. I do have diabetes again, and I suffer from atherosclerosis. So, the hypertension's one of those things I tried. Honestly, with medication, my blood pressure stays 130/90. As well as the amount of beta blocker that I take. Some other drugs you'll see is the ACE inhibitors, the angiotensin converting enzymes, because all of those ACE inhibitors, the beta blockers, calcium channel blockers, help to decrease that left ventricle pressure, thereby decreasing our hypertension. Syncope. Syncope is defined as transient loss of consciousness, usually anywhere between 3 seconds to a minute. Nobody really knows why people have syncopal episodes. There's a varied midst of reasons. Could it be a cardiac issue? Could it be a vascular issue? Could it be a psychosomatic issue? Of course, all of those issues are going on. But what we know is syncope, for whatever reason, we have a decrease of blood flow going to the brain, and the brain shuts down for a minute. It's sort of like a controlled alt-delete in that manner. All right. Standing still for long periods of time, all that other stuff. But again, you could read that. Cardiac syncope. This is why when we do have somebody with a cardiac syncope, we should hook them. We believe that we hook them up to the monitor, make sure they're not throwing runs of ETAC. Okay, make sure they're not running, PSVT somewhere. Make sure they're not in an idioventricular or something like that. When we look at individuals that have epileptic seizures or something like that, realize that prolonged syncope can lead to a massive electrical discharge in the neurosystem, which can lead to syncope. Can lead to seizures. And then we also have those TIAs, transient ischemic attacks, where we have a decreased blood flow to a given area of the brain. And again, syncope can be a precursor to more damaging cerebral vascular incidences. A little bit of neuro disorders, and again, as we get older, altered mental status. Can it be secondary to hypoxemia? Yes. Can be secondary to hypoglycemia? Yes. Can be secondary to DKA? Yes. So there's a lot of issues that we need to cover very, very quickly when we assess our patients. Neuro disorders can be affected again by mental status, cerebral vascular diseases, fluid electrolyte, nutrition, overall infection, UTI, lack of nutrients, medication related, whether they're taking too much of their drugs or taking not enough of their drugs, MI, seizures, overall structural changes, arterial venous malformations, rapid temperature changes, too hot, too cold. But again, these are things where we don't really know if this is a gradual progression of a chronic disease or if this is something new. We can only treat the life threats. And for us, honestly, ABCs, airway, breathing, circulation, O2, get a glucose. Never hurts to get a glucose. We can roll it out, We've taught, you guys have been learning ad nauseum with the hemispheres learning stuff regarding CVA, so I won't go into that. But again, please realize there's two types of strokes: hemorrhagic and occlusive. Occlusive can be fixed. We're extending that time to be, time to brain death much greater than we were previously. So get them to a stroke center, get them taken care of, assess them appropriately. Hemorrhagic strokes, a little bit different treatment, depending on whether it's a subdural, epidural, or, in the dura mater or something like that when it's intracerebral. A lot of different treatment modalities for that. So here we see just another nursing educator. Plaque, patients that have headaches, migraines, atypical migraines, should never be just, it's just a migraine, something like that. I've seen too many people in my career where, the 30-year-old comes in with a thunderclap headache. Oh, it's just a migraine. We discharge them, don't do a CT, don't rule it out. And then next thing you know, 3 hours later, they're being rolled back in cardiac arrest secondary to a massive stroke that nobody knew about. So things that go along with that, stroke, don't forget there's the FAST assessment. There's, everything that we use as far as that. And again, the stroke, we have altered mental status, coma, paralysis, slurred speech, change in moods, seizures, and using some type of screening, whether it's our version here in Pennsylvania or LA pre-hospital stroke, Cincinnati stroke scale, or something else like that. But again, identifying early, getting them to the facility where they can treat it to the best of their abilities. Now, one of the best type of treatment is going to be prevention. So how do we prevent stroke? Well, stop smoking, stop vaping, stop using recreational drugs, control the hypertension, good nutrition, moderate use of alcohol. They don't say stop drinking alcohol. This is something that's being changed along the way. They're actually finding out that a lot of the alcohol in moderation, whether it be ales, alcohols, and wines, may actually have some therapeutic properties to them. So having a beer or two after the end of work, stressful night, may actually be beneficial to your heart, as well as your neuromuscular and neurovascular progress. All right. So here we can see a couple other pictures here that end up having neurodeficit, causing neuro problems, can affect your TIAs, can affect your syncope. One is your hematocrit, which is the amount, the percentage of red blood cells in whole blood. Please remember, oxygen is not transported, any usable oxygen is not transported anywhere in the body other than on the red blood cells, okay? You need to have that hemoglobin, therefore the red blood cells, to be able to transport that oxygen around, okay? It doesn't matter how much fluid you put in the body, if you don't have a good red blood cell and hemoglobin and all that, and that's what hematocrit shows us, to be able to transport that around, it doesn't work. Some other things, when we end up having issues like hyperkalemia or a potassium deficit, not only do we get cardiovascular issues, but we also get neurological issues that go along with that. So please be mindful of that. It could be electrolytic considerations with that. Again, in the field, we can't pull blood samples out to define for sure, but we can see a little bit difference when we start looking at the obvious EKG changes, the hyperacute T waves, where we end up seeing, prolonged P and R, all that other stuff. With that, we can assume that we don't know for sure, but as our scope of practice increases and we maybe get, stats out there, iStats or something like that, maybe we can be, maybe a little bit of, and again, maybe lactated ringers has a little bit of potassium in it, but we're not given potassium, in the field or something like that, or anything to really fix that. But that's something that we got to be monitoring, in interfacility or, acutely. It could be differential diagnosis. Another issues neurologically are going to be seizures. Now, whether they're grand mal, with the tonic-clonic type, or petit mal staring or something like that, seizures are basically a massive electrical release of energy across the neurological system. Typically, most seizures are self-limiting, 1 to 2 minutes, but when they become status and the patient is not breathing, then it becomes problematic, because everything that goes along with not breathing causes things down the road. Things that can cause seizures other than your typical neuro diseases, post-head trauma, increase in intracranial pressures, along with epilepsy. We could see issues with the DTs, the alcohol withdrawal. Patients that are hypoglycemic as well as DKA, they can end up throwing seizures. Cancer or lesions, tumors or bleeds in the head that nobody is unaware of. We talked about head order, stroke, syncope, stuff like that. But the one thing that goes along with seizures is knowing the difference between a posturing. When we end up having decorrugate posturing versus decerabate posturing. Okay, decorrugate means things come to the core. They're coming in closer. Somebody that is decorrugate posturing is a little bit better than decerabate posturing. Still causes problems, but the decerabate means it's more interior of the brain. But again, what you'll see is individuals coming for decorrugate posturing, you're going to see them coming closer to the body. Things are being adducted rather than abducted, taken away from the body. The cerabate's going to be moving away. That's why if you ever watch any videos of individuals having a cardiac arrest, that they're in VFib or VTAC and it's a witnessed arrest, what you end up seeing is them kind of like stretching. It's just a massive release of electrical stuff going on in the brain, but it's a form of decerabate posturing. It's not long lasting, but it's quick, and it ends up going to nothing. So that's something to remember. Anti-seizures med that you should become familiar with as you go down: the Tegretol, the Neurontin, the Luminol, the Dilantin, the Depakote. Those are the ones that are most common out there. Please realize if an individual is taking anti-seizure medication, they're taking it because they have active seizures. If they stop taking it and they end up getting a seizure, it's called a breakthrough seizure, as well as if they end up trying to find a good, just like with antidepressants, they try to find a therapeutic level. There may be times when seizures go, if they are taking their medication and they're very honest about it, somebody's taking whatever, 100 milligrams of Depakote, well, they're getting seizures, those breakthrough seizures, then they may end up having to go up to 200 milligrams. So it's very important to ask somebody that does have an, especially elderly population that has seizures, hey, have you taken your medicine today? Are you sleeping well? Are you eating well? Because all of those things can lead to breakthroughs. Dizziness, vertigo, again, with the vascular issues, the atherosclerosis, the TIA, potential CVA, we can end up getting individuals complaining of dizziness and vertigo very easily. Dizziness, vertigo can be caused by dehydration, can be caused by cardiac issues, respiratory issues, all that other stuff. Motion sickness is a form of vertigo and dizziness. There is a disease out there called Meniere's disease that causes severe intractable vertigo, and it's usually caused by an inner ear disruption. Most of the time, Meniere's individuals, what will happen is because of the dizziness and vertigo, they will actually try to go to the lowest point they can find, which is, I always commented, is those patients go to ground. They'll try to put their head directly onto the ground, onto the bed, and they'll stay there and they won't move. The majority of the treatments for Meniere's is going to be a benzodiazepine. In the fact you give them a benzo, it will kind of separate the inner ear issue and the vertigo from the rest of the neurological system. Most individuals that do have Meniere's disease are well are well cared for and treated for, so it's not a big deal. But it's one of those side things. I took care of a Meniere's patient one time, second floor of a bedroom, and the poor woman was so diaphoretic and just literally laying on the floor, couldn't move her. And at the time, command wouldn't give me orders for Valium. I had to assist her because her husband wasn't there. I had to assist her with rectal suppositories of Valium. So it's easily treated. She ended up not going. She just couldn't reach around and do it herself. So it's one of those issues that go along with that. Hypoglycemia also, it's one of those things, and it's so easy to figure out whether or not somebody's hypoglycemic. Some other things that we go along into is organic brain syndrome when we start looking at delirium, dementia, as well as Alzheimer's. Alzheimer's is a general collection. It's the best known form of dementia, but basically it's global cognitive impairment. It can be progressive or it could be irreversible. And then when delirium typically is a global mental impairment that is of sudden onset, acute, and limited self-duration. Typically, somebody's not taking their antipsychotics, somebody's having anxiety issues or something like that, whereas dementia and Alzheimer's in that manner tend to be progressive ultimately and irreversible at the end of that. I put over here the 5 A's to Alzheimer's: amnesia, aphasia, agnosia, apraxia, as well as anomia. But also, when you consider all this stuff going on, you want to do a quick psychiatric assessment. What do they look like? Are they disheveled? Most patients of Alzheimer's diseases or dementia typically are in SNFs or something like that, whereas you get your psychiatric assessments going on, somebody's in the middle of a street or something like that. What do they look like? Do they look disheveled? Do they look like they're having an issue? What's their speech? Is it erratic? Is it erratic? Is it, jump around? What's their memory like? What's their mood like? Are they, hyperactive? What are their thoughts? Do they have thoughts of impending doom? Do they have thoughts of harming themselves or someone else? What's their perception? If they think that you're going to kill them, maybe it's more of a psychiatric issue at the time versus that organic brain. It can be an extension of it. But again, it's you got to be able to go in and ask those hard questions. And what's their orientation? Do they know who they are, where they're at, everything else like that? Alzheimer's patients, dementia patient, most of them revert back to a childhood memory with that. Some other neurological issues that are caused by, etiologies or causes of delirium: subdural, some type of head injury, something like that. CNS infections. You'll see individuals post bacterial, viral infections that had some type of neurological input. Heart failure, again, as cardiac output comes down, Hypoxia to the brain increases. Endocrine issues, post-concussion syndrome, PTSD, all these things can add on to it. But again, signs and symptoms include anxiety, inability to focus, disordered thinking, irritability, fearfulness, excessive energy, excessive depression, psychotic behavior, speech disorders, and sleep and eating patterns. Dementia is prevalent in the elderly. And again, we're seeing 55% of our population is old. Organic brain syndrome, again, senile dementia or senility sets in. They may have those TIAs, multiple strokes, atherosclerosis, age, people getting old. Overall neurology diseases leading into Parkinson's and all that other stuff, Alzheimer's, all those things that we go, dementia hallucinations, toxicity secondary from over and or under medicating of certain drugs. Now, Alzheimer's, just so you know, Alzheimer's is a type of dementia, but truly, Alzheimer's can only be diagnosed at postmortem. Now, with newer technologies, we can see CTs and stuff like that, but really, Alzheimer's, it's only true diagnosis like CTE can only be diagnosed secondary at postmortem. But it is a chronic degenerative disorder that basically breaks down the synapses, as well as decreasing the amount of tissue, of brain tissue that's in there. We'll see a picture here of the gyri and sulci, as well as the overall tissue where we've actually lost brain tissue. All right. In early stages, loss of memories, inability to learn new material, mood swings, personality changes, all the way up through the terminal stage, which basically we see a regression to the infant stage where they need help with everything. The ADLs are completely out the door. So here you can see up in the upper left-hand corner, a normal brain. This is an artist's rendering. The normal brain, it's full, it's hydrated. We have very small ventricles here in these areas. It's not atrophied, but when you look on the right here in an artist rendering of a brain that has an Alzheimer's issue, here you can see the widening of the ventricles, the overall loss of the tissue in that. And again, down here under the normal brain, the gyri and sulci are very fluid. They're there, they're big. Whereas you look at the one on the right, it looks dehydrated. And we see that overall loss of brain tissue. And that's why I say, despite newer technologies, the majority of diagnosis for Alzheimer's comes postmortem. Parkinson, degenerative disorder again. Only this one, this one is a neurological issue, but what we end up seeing is due to changes in electrolytes and chemicals in our body that help with the transmission of electrical signals. This one is outside the brain, actually. It's more like a cranial issue and those nerves. We see change in muscle responses, atrophy, tremors, loss of facial expression, gait disturbances. This affects the basal ganglia of the brain. All right. Viral encephalitis can also cause it. Atherosclerosis of the cerebral vessels. It can react, Parkinsonian shakes, reaction to certain drugs or toxins, metabolic disorders, tumors, head trauma, as well as overall degenerative disorders. And if you guys are looking for something to watch, in 1990, there was a movie made called Awakenings, and it starred Robin Williams as the researcher, Robert De Niro as the patient. It had the actress who voices Marge Simpson as the charge nurse. And it took place, it's a true story, in 1950s Brooklyn, I believe, New York, where the researcher was working on reasons why certain individuals diagnosed with Parkinson can go from very poor gait, shaking, Parkinsonian shakes, all the way to a catatonia. And what he discovered was it was a lack of L-DOPA. They had an excess of the R-DOPA, which is dopamine, and there's different forms, a right-sided and a left-sided. But what he found out, and this was well before, newer technologies where we can measure this stuff easier, but they actually found that they were missing a lot of dopamine in their system, which would cause them to stop moving because it's a neurotransmitter. And it's a wonderful story. And again, I'm sure it's, got some issues with it because it is a movie, but it tells you a lot about the medicine behind it. I highly recommend it. It's good. It's not a waste of 2 hours. All right. These individuals, again, they have resting tremors. They'll sit there. Pill rolling motion. It's like pill rolling motion is if you take your thumb and 2 fingers and roll them together. It's kind of like that. They're doing stuff like that. Kyphotic hallmark is the disease of the back. Mask-like faces are devoid of all expression. They just stare off. And if you want to see a good video, Google Billy Connolly Award with Dustin Hoffman. And if you know who Billy Connolly is, he's a Scottish comedian that was very broguish, very widely, but he's suffering from Parkinson's. And he went up to this recent award, and you can see how the Parkinson's is taken over. He has this blank affect on his face. He's still funny, but he just doesn't, if you look back and Google him and YouTube him, it's very interesting. Again, they speak in slow, monotone voices, so you can see that, as well as they have problems in overall communication, and they lose their mobility over time. Some of the big ones that you guys have become familiar with, but again, we see it more prevalence in the elderly. Diabetes mellitus, these individuals, it can be broken down into 2 types. DM, it could be type 1 or type 2, insulin-dependent diabetes, or type 2, non-insulin dependent diabetics. But regardless, we typically, as diabetics, typically have a poor diet, decreased physical activity, loss of the lean body mass. We get a lot of obese stuff. Somewhere along the way, we have an impaired insulin production. Insulin's produced as part of the islets of Langerhans, as part of our pancreas. That's typically in type 1 and type 2. What happens secondary to the obesity, and we don't have very good efficient use of the glucose because we lose insulin receptors as part of growing old on top of our cells, because we need the insulin to unlock the door to allow the glucose into the cell, which will then allow it to go into the mitochondria and all that other stuff, the Krebs cycle and everything else like that. Long-term can lead to neuropathy, visual impairment, hypertension. But typically the treatment for this is diet, exercise, using all that sugar, decrease your diet, low carbs, all that other stuff, as well as we watch our sugars daily. Patients who are a type 1 are always at risk at hypoglycemia. We give ourselves too much insulin, and we don't bring in enough food because we're trying to watch our diet. We're under stress. We have an infection. Something happens like that. Our sugars drop below 60. We become altered mental status. That's easily fixed. So taking a sugar is really important. The other thing is we can also become hyperglycemic. In that fact, typically a blood sugar greater than anywhere between 250 to 300 over time, where the introduction of excessive glucose causes fermentation, which then leads to DKA, diabetic ketoacidosis, acetone, which is a form of an alcohol, and that's where that fruity smell comes from. So if you have somebody that is altered mental status, they're being a jerk or even unconscious, but they smell of juicy fruit or a citrus fruit, consider the possibility that they're in DKA. Don't rule out that it possibly alcohol as well. It may be alcohol, it may be not. But again, when we document it, we don't put subjective information, we put objective information. Now, also with that, we also have poor, because of the diabetes and the buildup of the excess glucose, we also have poor vasculature, especially in our lower extremities, which leads to constriction, which leads to neuropathies, which leads to various conditions that can lead us even more problems. So here we can see here two individuals, type 1, type 2. All right, type 1's typically polyuria, increased urination, polydipsia. You're always thirsty, and usually when you're always thirsty, it's usually something that has a sugar taste to it. And then you're polyphagia, which is an increased hunger. You're always hungry. These individuals, because they're urinating out so much sugar, they end up getting weight loss. They end up having some, 10, 20, 30 pounds of weight loss in that. But with that, all that sugar, please remember, sugar is a huge molecule. And as it goes through the urinary system into the renal issue, that's why most type 1 diabetics down the road end up having renal issues. Type Type 1s are always fatigued, increased frequency of infections, rapid onset. Typically, we're usually insulin dependent. There's usually a genetic incident, and we'll see a peak incident from this from 10 to 15 years old. Individuals that have been diagnosed early on, that typically they're known as juvenile diabetics, but as you get older, usually becomes insulin dependent diabetes, type 1. Type 2, on the other hand, typically is adult onset. We tend to be obese. Okay, type 2 diabetics typically do not require insulin, but there is a subset that of type 2s that end up becoming type 1 because of the need for insulin. Typically, we're heavier individuals, sedentary lifestyle. There is genetic. Average age is usually 50 and above. I started getting mine right around 38 to 40. History of hypertension, or fatigue, have low output of energies, tend to be obese. Recurrent infections, polyuria, polydipsia, and an FBS stands for your fasting blood sugar that's usually greater than 126. And fasting means you have not had any intake other than like coffee, black coffee, or just water for 12 hours in that situation. So normally, without my medicines, I have a fasting blood sugar of about 230. My sugar without my medicine after eating, though, my dumping, I tend to go up to sometimes 400. So it's one of those things. But again, we're seeing a lot more of the type 2 diabetes because of the increase of obesity. Other things that we talked about, basically DKA, diabetic ketoacidosis. It's secondary to a large increase of glucose in the system and a lack of insulin. With that, these are an individual that basically get us, have that fruity odor of our breath. We're very thirsty. We're very dehydrated in that fact because as we drink, the water comes into the system, sent out to the cells to rehydrate everything because we've got so much glucose, we end up getting this osmotic shift with that. Typically, high blood sugar greater than 240 milligrams per deciliter, hyperkalemic, polyuria. For us, if we have somebody, the treatment for DKA, honestly, is an insulin drip. We don't carry insulin. So for us, the best thing to do while maintaining lung sounds, make sure we don't go into pulmonary edema, is give them fluid. Okay, 500, 1,000 liters, milliliters of fluid, rapid infusion over 15, 20 minutes. Maintain that airway. If they're unconscious, cuspal respirations, draw a glucose stick, find out what it is, put them on capnography, high flow O2, because again, they're retaining that CO2. It's causing even more. They become even more acidotic. People can die from this. And if it's really, 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 really bad and insulin doesn't take care of it and you take them to the ER, guess what? They're going to get dialysis. So. And then dumping syndrome is something that individuals suffer. You may even suffer it, but basically, if you take in a lot of carbohydrates very, very quickly and your body is not used to it, what will end up happening is those high carbs, those high carb fluids, sodas and stuff like that, as it transitions from the stomach to the duodenum where the pancreas dumps out all that insulin, basically what will happen is all that sugar will be brought into the system and you dump. And you get this horrible sense of weakness, nausea, vomiting, diaphoresis, and vertigo, tachypnea, abdominal cramping. It's usually very self-limiting, but it's nasty when you do it. And you'll see a lot of individuals do it that have had Geriatrics or stomach stapling because at that point they decrease the size of the stomach to about the size of your thumb. And if you take in and eat a lot of sugar, your body can't contain that anymore. So it ends up just dumping into the system. It's not slowly absorbed. It's dumped in there, and you end up getting these signs and symptoms. All right, so it's 9:57, everybody. I'm assuming nobody has any questions. Nobody's been chatting with me. So what we'll do here is we'll end here at thyroid. We'll come back and visit this on Monday. We'll pick up with, finish this out as well as start, I believe it's MCI. MCI is on Monday. And then we'll continue in Wednesday. We'll do something with that open class. And then we're coming up to the close. Like I said, I'm going to come up with a plan to get your flat student turned in. I'm slowly working through everybody's clinical paperwork. I got that all. Some of you have gotten emails back from me and or through Platinum as far as getting stuff corrected. So I'm going to continue to work on that. It's a slow, tedious process. But unless anybody has any questions, that's what I'll be doing. I'll talk to the crew, the teams tomorrow night. Please remember, tomorrow night I've got CMG at 6. I've got Maria and Vic at 7, and then I've got Sam and Brandon at 8 tomorrow night to go over your progress on your research paper. So unless anybody has anything, I'll see you guys those tomorrow and talk to you next week.